Thank you, Joe. So let's get into some of the cases, because I think a lot of the points that Joe and I have been making are going to come alive when we think about the cases that are in front of us. So this first case is a 59-year-old woman with psoriatic arthritis and problematic Achilles pain. She has a 5-year history of psoriasis and PsA. She doesn't have any changes on her x-rays of hands and feet, and CRP is normal. Treatment history is that she was tried on methotrexate initially, then adalimumab was added during her first year, but then because of inadequate or loss of benefit over time, she was switched to secukinumab. But interestingly, even though she had good control of her skin and nails, she had worsening of joints. So she was switched to ixekizumab, another IL-17A inhibitor, and found that she had benefit, but it wasn't complete. And then the other issue that she was having was injection site reactions. This was with the old formulation of ixekizumab. They changed the formulation now so that there's much less in the way of injection site reactions. And she has ongoing pain in her back area and upper buttock area, and even though she's had some steroid injections with temporary benefit for the SI joints, it's been only temporary. So she has switched therapies yet again to another agent, and this time she is switching to guselkumab and continuing with methotrexate. So here is her set of images, and I'll jump in and just tell you that the X-ray looks of the pelvis with the SI joints there, it looks pretty normal of those joints. We aren't seeing narrowing of the joints or periarticular sclerosis. But then we've got this sort of grainy MRI scan. This is an actual scan from our clinic. And you can see on the patient's left hand SI joint, the light up in the bone adjacent to the SI joint, consistent with lymphocytic infiltrate in that area. So it helps objectify the fact that she does have sacroiliitis. So now she's on guselkumab at its prescribed dosing of every 8 weeks. Pretty convenient for her, along with methotrexate. She's not on any steroid therapy. Current status is that skin, nails, and musculoskeletal symptoms are well controlled. She's not had any steroid injections, including the SI joints or other enthesial areas, over the past 10 months. She's got pretty just clear psoriasis, which we expect from the IL-23 agents. She's got a little bit of tenderness, but no swelling. So there's some potential confidence that she's not going to have progressive erosive disease, and she has no functional limitation, which is important. And really, the pain is not bothering her very much. And so, if we look at how we would go about assessing for enthesitis in this patient, these are the different Enthusitis measures that are used in clinical trials. On the left-hand side, the Leeds Enthesitis Index, which is the simplest, where you press on the lateral epicondyle at the elbow, the medial condyle of the femur, or the Achilles tendon insertion, and look for wincing on the part of the patient, or ask them about pain. Then in the middle, there's the SPARC, which is a Canadian-derived instrument in which there are more sites that we press on that can be characteristically involved with enthesitis. And on the right, the Maastricht Enthesitis Index, which is more commonly used in ankylosing spondylitis trials. Enthesitis occurs, and the reason we're focusing on this is that this patient originally had, the reason she's cycling through these therapies has to do with her Achilles tendon insertion disabling her. So these are the frequencies in various clinical registries that we see enthesitis. When we're entering patients in clinical trials, I must admit, we see more than this. We typically see 50 to 60% of patients with more active disease having evidence of enthesitis by pressing on these sites. And then also, if we pull out the ultrasound machine and take a look, then we often will see evidence of enthesitis by that means more objectively. So we have some still Achilles tendon pain at her insertion, but by and large, the rest of her disease is well controlled. And she is fulfilling what we call minimal disease activity criteria with just her pesky one area of enthesitis left over. So she's got a very low tender and swollen joint count. Her skin disease is virtually non-existent. Her pain is really not bothering her. Patient global, she's going to be judging low, and her function is full. So if she meets at least 5 of these criteria, then she's in a state of minimal disease activity. And if she meets all 7, then she's in a state of very low disease activity. So here we have listed the agents that we know are effective for treatment of enthesitis, and she's been each of the ones that she's tried are within this grouping, and is currently on guselkumab, an IL-23 inhibitor. And these are the domains that we would have applied in her case. We would have also thought about the axial disease because of her single area of sacroiliitis. So that's an example of how we sort of think through the domain approach to the disease. Are we covering each of these areas, skin, joints, entheses, spine, etc., and walking you through using the GRAPPA guidelines.